afternoon and many thanks to the organizers. I'm Salvatore Aversa, a neonatologist from Brescia in Italy. It's a pleasure to be here to talk about lung ultrasound in neonates. In the next 10 minutes, my talk will go from the basics of the technique to the main clinical application through the mention of the main ultrasound science. In recent decades, lung ultrasound has attracted increasing clinical attention, especially in emergency medicine, intensive care, and neonatology. Ultrasound is a highly sensitive and a specific modality for the diagnosis and monitoring of various lung and pleural conditions. It's a simple and expensive radiation-free tool that can be easily performed at the patient's bedside, also as a guide for interventional procedures. Lung ultrasound fits very well with the characteristics of the newborn, small chest, specific disease, and radiation-linked risk. These are just some of the recommended textbooks for further study of the theoretical part. These are just some of the articles that you can find in literature. 5 years ago, the European Society of Pediatrics and Neonatal Intensive Care became one of the main references in the literature on the use of point-of-care ultrasound. This guideline contains 11 recommendations regarding lung ultrasound with a high level of agreement. The main disease in which POCUS is useful are respiratory distress syndrome, transient tachypnea of the neonate, pneumonia, meconium aspiration syndrome, pneumothorax, and pleural effusion. Lung ultrasound has been also included in the crashing neonate ultrasound protocol, integrated with other POCUS like cranial, abdominal, and cardiac ones. Lung ultrasound is defined as artifactual because it's based on the analysis of ultrasound artifacts generated by the interaction between ultrasound and the aerated tissues. The paradox is that the disease uncovers the organ, which can be only directly visualized in the absence of aeration. These are the different ultrasound patterns that can be observed based on the degree of aeration of the lungs. Any machine with appropriate probe can be used to perform lung ultrasound, but it's important to turn off softwares and filters used to decrease image noise, as we need to evaluate the artifacts. We can use different probes: linear, microlinear, convex, microconvex, and phased array, but in the neonates, most clinicians prefer a high-frequency linear or microlinear probe. The interpretation shows good inter-observer agreement with all the probes, but by novice operators, the use of linear or microlinear probes can be better. This is an example of using the hockey stick probe. During the examination, the anterior and lateral regions are explored, while the posterior region is usually not performed in the critically ill newborns. Lung ultrasound can be performed in two planes: vertical longitudinal and horizontal transcostal views. It uses specific signs to indicate normal and abnormal lung conditions. This is the butt sign, the first step of any examination, where you can identify the lung surface. This is the pleural line. It's an aperoid line between the two ribs. The sliding of the two pleural leaflets is called lung sliding. The absence of lung sliding is always a sign of underlying pathology. An easy example can be a pneumothorax. A lines are the reflections of the pleural line. They reflect the presence of air in the lungs. This is a normal lung. We can recognize the pleural line and the A lines. As you can see, there are no other pulmonary findings. Here we have the B lines that are vertical dynamic artifacts that provide information on the interstitial fluid component in the lung. They move with lung sliding, obscure the A lines. The presence of more than 2 B lines per intercostal space defines an interstitial syndrome, with the exception of the transitional period in neonates. When the B lines are particularly confluent, they give us an image like this, which is defined as white lung. This is a consolidation. Almost all consolidations have irregular boundaries with the underlying aerated lung called shred sign, seen at the deep border of the consolidation. Microsubpleural consolidations are commonly seen in severe RDS. So, in case of pneumonia, we can observe pleural line abnormalities and lung consolidation with disappearance of the lung sliding that sometimes is replaced by the lung pulse. That is the consequence of the lung movement simultaneous with the heart. A limitation of the lung ultrasound in pneumonia is that we cannot see a consolidation that is not in contact with the pleura because of the interposed air. In many large consolidations, bronchograms can be observed, but it's often difficult to distinguish between static and dynamic bronchograms, possibly because of the small tidal volumes in the unit. The clinical context is essential for making an accurate diagnosis. This is a free fluid in the pleural cavity that is easily identified by the lung ultrasound. Lung ultrasound allows not only accurate identification and bedside monitoring, but also an ultrasound-guided thoracosynthesis. All these signs can be used in combination as a diagnostic aid in a systematic approach, or by summing the scores assigned to different ultrasound images in the various lung regions and obtaining a score. For each view, we assign a score, and by summing all these scores, we can grade the disease. And, for example, predict surfactant requirements in preterm infants with RDS. Using a cutoff of 8, ultrasound would be more accurate than the FiO2 threshold to identify babies who need surfactant administration. For example, in this preterm infant with clinical signs of RDS, we can give 1 point at the right upper anterior view and 2 points for each other views, for a total score of 11. And in this other case, 1 point for each views, for a total of 6 points. Lung ultrasound can be used to detect transient tachypnea in newborns, where we can observe confluent B lines in some lung regions, alternate with spared areas in the other ones. This is an example of double lung point that we can observe in the 50% of the cases of TTN. We have compact B lines with wide lung at the bases that are less aerated, and non-compact B lines at the apices that are more variated. Lung ultrasound is able to identify RDS through the bilateral detection of these three ultrasound signs, which homogeneously affect both lungs. So abnormalities in the pleural line, white lung, and absence of spared areas in all lung fields. This is an example of meconium aspiration syndrome, where we can observe lung consolidation and different patterns in both lungs at the same time. In pneumothorax, we have the pleural line without pleural sliding and the absence of B lines. We can also see the lung point, that is the transition between the pneumothorax and the normal lung. It's also important to talk about the lung ultrasound limitations. We can observe lesions just if they are in contact with the lung surface. It is not possible to detect overdistension in an air-filled lung, and it needs a systematic evaluation. The take-home messages would be that lung ultrasound is a simple technique, but it needs to know the clinical condition for a systematic approach. At the end, it takes a lot of practice. So you have to practice, practice, practice. Many thanks for your attention.